Hi, everyone. Welcome. As everyone is joining, it's 4 o'clock, so we'll give us just another minute and we'll get started. Okay. Great. Well, thank you again for being here. My name is Faith Osborne. I am a social worker at Gift of Life Howie's House. Thank you all for being here again at this month's webinar, Transplant Dermatology, What You Need to Know, presented by Mark Abdelmalek. Hopefully I got that right. And this program will review the importance of comprehensive and multidisciplinary care for all solid organ transplant patients. Dr. Mark's goal is for no one to die from skin cancer after a solid organ transplant. And this talk will review the risks and most effective ways for solid organ transplant patients to prevent, detect, and treat skin cancer promptly. So let me share my screen and we will go through some quick housekeeping. So this webinar is hosted by the Caregiver Lifeline program, which supports and educates transplant caregivers and patients within Gift of Life Howie's House throughout the Gift of Life donor program region, as well as nationally and internationally. So some services that the Caregiver Lifeline program provides are virtual education, like this month's webinar, support groups for both transplant patients, caregivers, and pediatric transplant caregivers, as well as a Facebook group, and up to 5 annual CEU programs for both dialysis and transplant social workers throughout the year. Our upcoming webinars will be May 3rd, working with your transplant financial coordinator, and May 17th, the key role of patients and care partners in transplant research. So you can scan this QR code here. We will also be sending out an email tomorrow with all of these resources and links as well. Again, here are the flyers and QR codes for those support groups. These will also be put in the chat through a link and also included in the follow-up email that you'll receive. And just some quick housekeeping. We encourage you to please use the Q&A for any questions that you have for Dr. Mark throughout the presentation today, and we will have time to address those all at the end of the presentation. But we do encourage you to utilize the chat box to introduce yourself, share your transplant story, or talk amongst yourselves. And again, a reminder, an evaluation will be emailed out to you tomorrow, as well as all of the resources mentioned in today's presentation. And as always, any specific transplant related questions to your own medical transplant journey, please always consult with your medical team. And as always, we would love to thank our committed sponsor to today's webinar. CSL Behring is a global biotechnology leader driven by their promise to save and improve lives. Their ability to innovate and deliver life-saving medicines for patients with rare disease and other unmet medical needs around the world has earned them a reputation for always putting their patients first. CSL sees significant unmet needs in transplantation and are committed to delivering innovative solutions to address them. So thank you so much to CSL Behring for sponsoring today's webinar. And finally, I'm happy to present or introduce our presenter for today's webinar. Dr. Mark is a highly regarded skin cancer surgeon and is a dual certified dual board certified in Mohs micrographic dermatologic surgery and dermatology. He is the founder of Dermatology of Philadelphia, Mohs Surgery Center, which opened in Philadelphia in 2020. As a board certified and fellowship trained Mohs surgeon, Dr. Mark specializes in the precise surgical removal of skin cancer with expert reconstruction. Dr. Mark is an adjunct professor, associate professor of dermatology at the Perelman School of Medicine at the University of Pennsylvania, and a co-founder of a unique academic dermatology center for transplant patients built on the collaborative work of transplant physicians, medical dermatologists, and surgical dermatologists. The Dermatology Center for Transplant Patients has become an innovative model for new transplant centers across the country. Dermatology of Philadelphia dermatologists continue the legacy of excellent care for solid organ transplant patients and other high-risk skin cancer patients. We do so in close collaboration with the patient's general dermatologist and transplant team in both New Jersey and Philadelphia. In 2016, Dr. Mark was honored by his peers with the prestigious Philadelphia Dermatological Society Founders Award for devoting extraordinary time and talent as a teacher and clinician. He has also been recognized by Castle Connolly and Philadelphia Magazine as one of Philadelphia's top doctors and rising stars in medicine. Dr. Mark feels honored to bring academic excellence, compassion, and conversation to the greater Philadelphia area, community, and patients. So thank you, Dr. Mark, so much for being here. I will stop sharing my screen and take it away.
Okay, can you hear me? Good, okay, now let me share my screen. Share. Uh-oh. 1 second, we need a password to share the screen.
Sorry, Dr. Mark, you said it's not letting you share?
Yeah, it's just saying we need an administrative password. Give me 1 second.
That's weird.
Yeah, I think it's on our end.
Thanks everyone for sharing in the chat.
Yeah, I've been reading the chats. It's like we have a wide audience here. Let me see here. Give me one.
And if you want, if you need to email it to one of us really quickly, we can always share it.
Yeah, let's do that. Let's do that.
Yeah.
Let's do that. I'm sorry. Okay.
And in the meantime, if anyone has questions, you can put it in the Q&A or the chat, and we'll definitely get to it at the end.
All right. I think we got it.
Oh, okay.
You would have thought by now.
Yeah.
It's making me leave the webinar, but
So sorry everyone for this technical difficulty. Please stay on. He'll be back very shortly. And I think if we need to stay on for a few minutes longer because of questions, like I'm sure we'll be able to do that. In the meantime, does anyone have any like anniversaries that have just happened they want to share? Personal transplant, anyone recently have a transplant? I saw someone just got listed, which is really exciting.
all right. Is that working?
Yes.
Yeah.
Okay, sorry about that, everybody.
It's okay.
All right. Okay, let's go. I want to pull up the chat so I can make sure I can see the questions at the same time. And here we go. All right. So thanks so much for that wonderful introduction. It's an honor to be here. And I've already seen in the chat that we have some familiar faces from people that I've crossed paths with in our time as being transplant dermatologists and transplant multidisciplinary teams. And I think one of the things that you're going to realize very quickly when you see this talk and hear this talk is that this is really a team effort. And almost in a way, dermatologists are a little late to the game in the world of transplant. I mean, in the beginning, we didn't really think that dermatologists had anything to do with transplant medicine. But what we've quickly realized, because things have progressed so much in the field of transplant dermatology, is that dermatologists really do play a key role. And I hope we'll be able to tell you why throughout this talk, and really see some examples, and maybe everybody can take something away that they can use in their own journey. So I want to just start by saying that I don't have any conflicts of interest to disclose. And here we go. Here we are at really a historic time in the world of transplant medicine. If you were paying attention to the news last year, just even almost a few months ago, less than 6 months ago, the United States passed more than 1 million transplants. So we've been tracking the numbers pretty carefully since 1988. And in around September of 2022, we had our 1 millionth transplant. Who knows, maybe that person is listening. I don't think we have the details, and they haven't been made public about who that was, but you know, the UNOS has definitely recorded the milestone, and we even have a nice logo to remember that. But it's really an amazing journey that we've been on. Right now, you can see how many people who are waiting for a transplant. And this was, I checked the numbers just a couple of days ago, and you can see it's still a significant number. You know, over 100,000 people are waiting for a transplant. Somebody on the chat said that they just were added to the transplant list today. And, you know, they are in this slide right here. And as you guys, I don't need to tell you because everybody here knows this, but one organ can save 8 lives. And the more we talk about it, the more people celebrate transplant, the more people hear about it. You know, they can be some of the worst days in people's lives and some of the best days in people's lives. But one organ donor can save 8 lives. And you also are noticing different things on the list, you know, combination transplant, intestines, and there's even other things that aren't on this list. But you can probably glean from this slide that kidney is the most common organ that we do transplant. Like I mentioned a few minutes ago, we're here as dermatologists and involved in this discussion because organ transplantation is so successful now. You can see the 5-year survival for various organs is really high, 80% 5-year survival for kidneys, you know, high 70s for heart and liver, and lung is our most challenging organ, you know, as you can imagine, but even lung patients do really, really well. I have patients who I take care of who have lung transplants who've had them from decades ago. So it's really an amazing time to be a transplant recipient. So why do we need transplant dermatology clinics? The main thing that we've realized, and you heard the introduction, we want to make sure that no one dies from skin cancer after getting an organ transplant. You've come a long way. It took years of dialysis, years of being on a waiting list. You finally have this organ and a new chance on life. And what we realized is early on, many people didn't live long enough to realize that skin cancer was a problem. Fortunately, we're not in that position anymore, and transplant patients do live for decades and decades. And with that, we start to see some side effects. And unfortunately, skin cancer is one of those, and that's what we're going to talk about today. But there's plenty of hope. There's things that can be done to prevent you from getting skin cancer. And there are ways to approach transplant patients with skin cancer to make sure we maximize outcomes, getting prompt skin cancer treatment, making sure you raise your hand and let your transplant patient teams know, especially your dermatology offices, that you are a transplant patient. And then the other thing about this is that we want to use this time for gathering our thoughts and putting it to good use. And power in numbers here with education and research. And the more that we do this kind of thing and learn from each other, the better all of us will be. I don't know if any of you have heard about this group. It's called the International Transplant Skin Cancer Collaborative. And because of all the things that we just talked about, it's about 20 years old now. It's a group of dermatologic surgeons, mostly Mohs surgeons, dermatologists, and we've recently added people from other specialties into the group who are researchers who are looking at ways to dedicate themselves and to advance the care and understanding of skin cancer and organ transplant patients. I mean, these are the brightest minds in dermatology, in dermatologic and Mohs surgery that really put their heads together to make sure that we are doing everything we can to take care of the patients. You know, they have conferences a couple of times a year. I've attended some of them. We have, you know, listservs where we can exchange ideas among transplant physicians, among transplant dermatologists. And every week there are posts that go around, hey, I have a patient in Cleveland who needs this. What do you think? Or, you know, I have this experience. Has anybody tried this? And it really is open the access for communication for us to do the, you know, the best we can for our transplant patients. You know, I'm trying to do a little play here on the how it started, how it's going. It's not a very tech savvy approach, but I started really learning about and working in transplant in around the year 2011. So 2011, 2012. And how it started was a small group of dedicated dermatologists on one floor in Philadelphia. We sat around the conference table. We had a really good mentor who was a nephrologist, a transplant nephrologist, who sat us down and said, look, we have a way that we can further care for our transplant patients. What do you think? So we sat around, we developed a Center for Transplant Patients. It formally opened, and for the first time, we had something called a dedicated transplant clinic. And when we often said transplant dermatology, almost nobody knew what we meant. They thought we were doing skin transplants, which is the furthest thing from the truth. And at the time, you can see that we had a little newsletter advertisement and a news article about us just in our local university about a new transplant center. How it's going is a lot different now. In 2023, if you go on YouTube, there are videos about this. You know, 12 years later now, transplant dermatology is a part of our everyday practice and experience. You know, being in academic medicine, we trained a whole crop of residents. You know, I estimated at about 40 plus residents in dermatology and other specialties that went through our program when we were focused on transplant medicine. And they've all spread out throughout the country with built-in transplant dermatology experience. In the beginning, like I said, we had dedicated clinics. It was one day a week. We weren't sure when people would come. You know, eventually we started to get a lot of patients. But now, for example, in my current office, our entire office is on board. Everybody knows that if you have a transplant patient, they're a VIP. Medical assistants know, the front desk knows, medical students know, even our non-clinical teams know, oh, this is a special group. And we've even developed special flags in our electronic medical record where we can put a section that says, this is a transplant patient. If they call, don't make them wait. And they know this, and we really get to know them in the office. Sorry, I'm having difficulty with the slides. Okay. Here's another how it's going and where it was. So I did a little search in the Journal of the American Academy of Dermatology, which is one of our main journals. And it's just one of the journals, so it doesn't mean everything. And I just wanted to know how many papers were out there in the year 2011 on transplant. And there were literally, you can see about 1,000. If you look now, I don't know what's going on with give me 1 second here, guys. Oh, if you look now in 2023, same exact search, there are 4,000 papers on transplant in the journal dermatology literature. And again, this is just one journal. There are actually many, many more. So when we opened the Center for Transplant Patients, we wanted to look, we weren't sure who was going to come knocking. This is the population that we saw. It was about equally split male and female, average of 52 years old. And you might notice something a little bit different in our demographics of our race breakdown. We had about 40% white, 49% black, and then the rest were Hispanic and Asian, which is a unique population and really an understudied population of people with darker skin types. So we had more people in our clinic with darker skin types than with lighter skin types. And then you can see the different types of organs that we had. Most of them were kidney. In transplant patients, sometimes they're just like everybody else, and they get things that everybody else gets: acne, inflammatory rashes, scaling on their face, pigmentation changes. And we started to notice that these are certain patterns of things that dermatology transplant patients get. And we also started to notice a pattern about when they were getting these things. The previous slide was mostly about the benign things or the pre-malignant things. What we also quickly realized, and everybody knows now, is that there are also skin cancers to worry about. So pre-malignant skin lesions and malignant skin lesions. And here are just a couple of examples of the things that you start to need to be looking out for if you're a transplant patient, and especially if you're a transplant dermatologist, you want to be able to recognize things. So pre-cancer, which is right here on the left in orange. And then the three kind of common cancers are basal cell and squamous cell. Those are the two most common. And then the third one is melanoma, which is the more serious type. So you can see that, you know, almost a quarter, 22%, 1 in 4 to 1 in 5 patients had either a pre-malignant or malignant skin cancer. So 5 years later, we published some more data, you know, further looking at the analysis. And these are my colleagues that, you know, worked from the beginning of our time together. And we saw that after 5 years, these were the patterns of things that we were seeing. And notably, the thing we really realized is that we did have a unique population of darker skin types, and the needs there are slightly different. For example, where you get a skin cancer, oftentimes in light skin patients, we talk about sun-exposed areas, but in darker skin patients, it's not always in sun-exposed areas. And I know there was a question in the chat about darker skin types and, you know, do they kind of get a different pattern of skin cancer? And yes, we're going to show you some of that in a little bit. So when you think about 5 years, this paper was published in July of 2020, and you're wondering why there's a COVID headline. The paper with our 5 years of data was published in July of 2020. And around that exact same time, you can see how far things have come. This is a story that I was working on at the time. And you can see the headline is pretty striking now with what we know. Why scientists think COVID-19 may be spread through particles in the air. I mean, this is just 2 or 3 years ago, and look how far we've come in our thinking on that. So I want to go over the most common types of skin cancer and things you want to catch early. Basal cell skin cancer, I know that in the chat people have already talked about it and had Mohs surgery for it, is the most common type. It's usually not a threat to your life. It very rarely spreads, but it's not unheard of, and is easily curable, especially when caught early. This is the kind of skin cancer we are happier to see. Obviously, we're not happy when anybody gets a skin cancer, but when we see a basal cell, you can breathe a sigh of relief. Squamous cell carcinoma is the second most common type of skin cancer for the normal population, but it's the most common type of skin cancer in most transplant patients. There is a subset of our data that showed that in darker skin types, it's not always true, but you can think about this as the kind of skin cancer you really want to make sure you're looking out for and detecting early. It is usually related to the sun, but not always, and especially in transplant patients, and like I mentioned, in skin of color patients. It can be a threat to your life. So squamous cell is not something that you want to just leave and you want to ignore. It is something that you want to treat and have a really frank discussion with your dermatologist about how to treat it. It can spread if left untreated. And the good news is it's very often curable, especially when caught early. Melanoma is the more serious, less common type of skin cancer. We don't have, even though we know a lot about melanoma and a lot about skin, we don't know about why we see melanoma, even in normal patients, but especially in transplant patients. It's a combination of sun and genetics, unknown factors, and immunosuppression. I see in the chat, somebody posted a question about, well, why do people get these skin cancers? And Jeff, we're going to get to that in a few slides, but you will see some reasons why. The most important thing about diagnosis with melanoma is that you want to catch it early. Just like squamous cell, you want to catch it early. It's not something that you want to watch for a long time if you notice a spot like this on your face. So here was another question that we had out of the chat. After a biopsy, this is the exact question that somebody asked. After biopsy and a confirmed diagnosis of either squamous or basal cell carcinoma, is it dangerous to wait to have Mohs surgery for another month or two? Does it give the cancer more time to spread? And the short answer is yes, it does, it can. For melanoma, the answer is do not wait. Studies have shown that you have better outcomes with treatment of melanoma within 30 days. And most of those studies are in people who don't have transplant patients. So we do know that skin cancers grow more quickly, can be more aggressive, and progress faster in transplant patients. So we do not like to wait for a melanoma. I like to tell patients 2 weeks. And when people call our office with a melanoma, we save slots for them so we can get them in within 2 weeks. Squamous cell carcinoma, I know sometimes it's tempting to not have them treated right away, but the sooner, the better. And what I like to tell patients is you should have a real compelling reason if you're going to wait. You know, you have a trip booked and you've already booked it and you're going on a cruise and you just get diagnosed. I don't know that you have to cancel your trip that's coming up in the next 2 weeks, but we don't want you to wait long. And it's also important to read the fine print on your pathology reports. And sometimes you need your help of your dermatologist to do this because some squamous cell carcinomas are what we call poorly differentiated, meaning they don't know how to behave nicely and they can grow rapidly. Those you don't want to wait. Now, if you do have a basal cell carcinoma, those can be slow growing, but they do still grow. And you can sometimes wait weeks for those. Those aren't very urgent that you get in. Now, here's an example of a reason why you don't want to wait. This patient had a squamous cell carcinoma, and the picture on the left is what it looked like when we first saw the patient, and it almost doubled or perhaps more than doubled in size in just 2 weeks. This is why you don't wait. So what are the risk factors for transplant patients and for getting skin cancer? A couple of things is something called Fitzpatrick skin type. That is essentially the amount of pigment you have in your skin and how your skin behaves in the sun when exposed to the sun. So skin type 1 is the lightest, 6 is the darkest. So we see most of our problems in people with skin type 1, 2, and 3. And you can go online and take quizzes about what your skin does in the sun to figure out what skin type you are. And I actually encourage you to do that. One of the things we know as dermatologists is the nuance is that really, I can't look at you and tell you what kind of skin type you are. It's really how your skin responds to the sun. So you really need to take the test yourself and know what your Fitzpatrick skin type is so you can report that to your dermatologist. Cumulative sun exposure matters. So the more sun you see, the more at risk you have. So if you're often going to the pool or the beach, you're an outdoor worker, you're a golfer, you're a runner, those are people who need to be paying really close attention. I have a transplant patient who not only has one pool, but now has a second home and has 2 pools. And I'm really not happy about it. And he actually may be listening. I'm going to get to Lewis's question now about does a prior history of skin cancer expose you or play a role in your transplant cancer risk? And yes, it does. And we'll get to it. Immunosuppression is the most important risk factor in a sense, because that is the reason why you're getting a transplant related skin cancer. And I'll tell you more about that in a minute. Organs. Because the heart and lungs require more and higher immunosuppressive doses, those people tend to get more skin cancer. And then kidney and liver would be less. If you have a previous transplant, you're more likely because you have a longer time of being immunosuppressed. Here's Lewis to answer your question. If you have a squamous cell carcinoma before a transplant, so that means even before you got on board with immunosuppression, you were having problems with skin cancer, that is a red flag you need to let your dermatologist know about, because for those patients, it's almost a guarantee that you're going to get another skin cancer after transplantation. And I'm not saying that to be a downer. I'm saying that to be a realist, so you know that you need to really be the front of the line when you're talking to your dermatologist, especially if you notice a spot growing. The more time goes on, you're going to have an increased risk of getting a transplant, but also the older you are at the time of transplantation. Having an HPV infection can increase your risk for a skin cancer. So it's almost like a 2-hit phenomenon. HPV, which is a virus and can by itself increase your risk for skin cancer. But if you also have that with sun exposure and immunosuppression, it can increase. And also people with a history of, unfortunately, lymphoma and leukemia. So one of the ways we can learn is from each other. And this was one of our very first transplant patients that we took. It was a 28-year-old patient who had a kidney transplant after years of hypertension. And you can see it's a young person. And then they also ended up coming to our clinic, but you'll notice at what age did they come to our clinic? At age 34. So it was 7 years after they have a transplant by the time they came to the transplant dermatology clinic. And nowadays that happens less and less often, but it does still happen, unfortunately. So Deborah asked in the panel in the question about what immunosuppressors increase your risk, and I will get into that in a second. Yes, there are some that put you at higher risk than others. So this is somebody who walks in the door on their very first day, and you can see here that they have 1, 2, 3 biopsy-proven skin cancers, and then a couple that we didn't even biopsy. A few months go by, and they have 2 more skin cancers. So you can see that 7 skin cancers ended up happening in this patient in 2 years. And because we were working closely with the dermatologist and the nephrologist together, we were able to have an open line of communication about this patient's history. And really, we identified this person as a high-risk skin cancer patient because of their age, the number of skin cancers they're getting, the amount of sun they were getting. And we start talking amongst each other about things that we can do. And you can see the nephrologist's response to the situation is, well, we might need to reconsider the immunosuppression or the medicines that they were taking to lower their immune system. And this is really another important milestone, is that now across the country, we're starting to realize that this type of coordinated care between dermatologists and nephrologists and surgeons and cardiologists all needs to happen to really provide optimum care for higher risk skin cancer patients. So what this patient taught us was you need to start seeing your dermatologist early, and your doctors need to be talking to each other about you. So let's get into a little bit more about squamous cell carcinoma, because again, I want people to start realizing that this is the one you need to pay attention about. Most of the time, this is the skin cancers that patients with transplants get, 95% of the time, and 75% of the time, it's in areas that is photo-distributed or areas that are in the sun. So 25% of the time, it would be in non-sun exposed areas. And those are, basically things where your clothes cover, and sometimes it's in the genitalia, unfortunately. If you have a skin cancer, like we talked about before, there is nearly a 100% chance of getting another one after a transplant within 5 years. And we talked about skin cancers as squamous cells being a little bit more aggressive. And this is why we want to treat you early, because the risk of metastasis, or when the cancer spreads in transplant patients, is much higher if you're a transplant patient than if you're in the general population. So 1 in 5 Americans will get skin cancer by the age of 70. That's all of us, whether we have a transplant or not. But here is the hard truth about skin cancer in transplant patients and why you should be in a transplant dermatology clinic. Squamous cell carcinoma is 65 times higher in transplant patients. Basal cell carcinoma is 10 times higher. Now, fortunately, melanoma does not have a dramatic spike in transplant patients. And again, melanoma is the more serious type of skin cancer, but there's only a 3 times higher risk of melanoma in transplant patients. Kaposi sarcoma is a rare one, and I'm not going to get into it too much. Hopefully none of us ever see that, but it's a type of cancer of blood vessels, and that is also related, it has an increased risk in transplant patients. And then pre-cancers, we see them getting a higher risk. Somebody said in the chat that even before they were going to get a transplant, they had to be seen by a transplant dermatologist. And that is also a trend that we really enjoy seeing, because not because we have to see if you have a skin cancer, but we need to start this kind of important conversation. Somebody asked in the question, does the probability of skin cancer increase, decrease, or remain the same the longer you have a new organ? Also, is melanoma hereditary? And this person happens to be 6 years post-transplant. So unfortunately, the more time that goes by, the higher the risk of getting a skin cancer. So here you can see the numbers. 5 years out, there's about a 7% increase in the risk of skin cancer. This is data out of Australia. 10 years out, there's a 10 to 45% incidence of skin cancer. And if you make it to 20 years out, there's up to an 80% incidence of skin cancer. Again, you can see heart and lung transplants, the renal transplants, and like we talked about before, sometimes the ratio of basal cell to squamous cell flips, as in sometimes we see in liver transplant patients. Is melanoma hereditary? And this really isn't a slide that I need to focus on for transplant medicine, but just because it was in the question, I wanted to go over it. And this is for everybody. Is melanoma hereditary? Most of the time, no. There is something called familial malignant melanoma, and that's if you have 2 or more first-degree relatives having melanoma. Is it genetic? We don't really know, but we do know that we're beginning to identify certain genes that are associated with familial melanoma. And if you have a mutation in either of these genes, then you can have an increased risk of melanoma. But even if you have familial melanoma and you're noticing a pattern, most of the time, it's not related to any gene that we know about. Could there be other genes? Perhaps. For example, we've recently discovered some other genes, including BRCA, which you may have heard about with breast cancer, that some BRCA2 mutations do have a slightly increased risk of melanoma. And sometimes you'll hear your dermatologist ask you, do you have a history of pancreatic cancer in your family? And that's because sometimes these things travel together, pancreatic cancer and melanoma. Again, this slide is really not specific to transplant, but just more to answer the question about is melanoma hereditary. So transplant patients, again, we really want to put you to the front of the line. We want to make sure we see you if you have a squamous cell because you have a higher risk of recurrence. So we looked at some patients, and this is not research that I did, but transplant patients in San Francisco, heart and lung transplant patients, and we see that the median time to recurrence for a skin cancer to come back in a squamous cell is 6 months, and that's, you know, pretty quickly. And it's only if you have a high risk skin cancer. So either there's something about your skin cancer that made it more aggressive, or, you know, it was large or it had already spread at the time of biopsy. And that 6 months is compared to 4 years for people who are immunocompetent, who have not had a transplant patients. We're going to get to Jeff's question about is immunosuppressant medication, which ones are more correlated with skin cancer in a second. So here everybody wants to know, because you all have these medications on your list, is immunosuppression a risk factor? And yes, it's a game changer. It changed the whole field of transplant medicine. It's the reason why you're sitting here and you're able to have a functioning organ. But it also changed the game for skin cancer for 2 reasons. One, there are direct side effects of the medicines that you're taking. So Cellcept, cyclosporin, tacrolimus. There are direct side effects, and these things actually can harm your DNA. So that's one reason why you get a skin cancer if you're on these medicines. And then there is something called indirect effects. So it's because these medicines are lowering your immune system, and our immune system is the most important thing we need to detect and fight skin cancer. So we're dampening the immune system's response to skin cancer. Believe it or not, your immune system can recognize skin cancer and can say, oh, this is a cell that's behaving badly, either because it recognizes markers on it or it recognizes the pattern of inflammation around it. And your immune system is great at detecting skin cancer. Unfortunately, when you take these transplant medicines, we're telling your immune system to calm down and chill out and not pay attention so much. And so therefore, it's letting skin cancers perhaps grow unchecked. So what to expect and when to expect it? Everybody's asking about when. You'll notice at the bottom, the key time to really start paying attention is about 5 to 10 years out. But once you are enrolled in a specialty transplant dermatology clinic, and all of those patients, when we put all of our heads together and all the patients together, we start to recognize patterns. You know, at 1 month, this happens. At 3 months, this happens. 6 months, this happens. Most of the side effects are rare and you won't ever see them. But you should really know your medicines and be able to tell your transplant dermatologist what your medicines are so that they can help recognize important things. For example, you might see acne in the beginning. And again, that's not really a huge deal, but you might be wondering why you have it. Oh, well, we know that, you know, around a 1 month or 1 week time period, acne starts to develop after transplantation. And that's not a big deal. You know, sometimes if you're on cyclosporin, you might notice changes in your gums, or you might notice different hair growth patterns. Again, not a huge deal, but we start to notice these patterns. 1 year, you can start to see some alopecia, things like that. Between 1 and 3 years, we start to see some side effects of having your immune system being in a lower state for longer. So you start to see some certain viral things. And a lot of these things are just nuisance things. They're not even a big deal, but they are important to recognize so that you can start treating them and intervening. For example, HPV lesions can start to crop up. Herpes lesions can become more common. If you have eczema, you can get on top of it a herpes infection, and that can be more common in that few year range outside. Also, fungal infections can become more common in the 1 to 3 year range. But mostly what we're talking about here is skin cancer and how important that is and when it becomes common. So here are the medicines that we're talking about. Prednisone, a lot of you take it. Fortunately, prednisone doesn't do a lot to increase your risk of skin cancer. A class of medicine called calcineurin inhibitors, cyclosporin, tacrolimus, and you probably are recognizing these names because they're on your list. Anti-proliferative agents, mycophenolate mofetil, azathioprine, and the newer category is something called an mTOR inhibitor, sirolimus, everolimus. So the question that was in the chat was, do both tacrolimus and CellCept cause a higher risk to develop skin cancer, or does one do it more than the other? And you can see here in the middle in the gray bar, the rates of skin cancer. So the worst offender is cyclosporin, and you see less and less patients on cyclosporin. Tacrolimus is a little bit better than cyclosporin. mTOR inhibitors and azathioprine and mycophenolate mofetil are all lower than cyclosporin and tacrolimus. So you might be on one medication, then as time goes by, your doses of that gets lowered, and then your transplant physician will increase and turn the dial up on other ones. Now, as dermatologists, we know what to do, and sometimes that is stay in our lane. We do not like to make strong suggestions or really interfere with your immunosuppressive regimen, and I will never make a change to a patient's immunosuppressive regimen. Usually that is reserved for the transplant nephrologist or transplant cardiologist or transplant hepatologist. Now, we're often involved in the discussion about, is it time or should it be? But we will never make this change in isolation, and nobody should do it in isolation. These are conversations you have to have with your transplant team, because yes, you're at risk of getting a skin cancer, but the consequences can be much greater if we do something to your immunosuppression, and now the organ that you had transplanted becomes at risk. Quickly, I'm going to go over these because it's just fascinating, but patients on azathioprine, there was a new study that came out in 2019 where they actually looked at mutations in skin cancer, and patients on azathioprine had a specific mutation. This is really in the weeds, but a C to T mutation, which is this red thing here, really lit up. And those are mutations that were seen in squamous cell patients who were on azathioprine. So it's almost like the azathioprine is targeting specific things, and we know those mutations can increase risk of skin cancer. Calcineurin inhibitors, they allow DNA to be damaged. And when DNA goes undamaged, especially after ultraviolet light radiation, that's what gets skin cancer growing. Cyclosporin can allow skin cancer by allowing skin cells to live longer even after damage. And then a few other reasons why we don't really understand, but induction therapy can sometimes, which is what you do right around the time of transplant to preserve that organ, can increase your risk of skin cancer. Now, there is a silver lining with immunosuppression, and that is that certain immunosuppressives, and some of you might recognize the name sirolimus, actually has anti-tumor and anti-angiogenic or anti-blood vessel properties. And when you start these medicines, you can see a reduced incidence of malignancy. So this is a medicine that we actually like to see. And like I mentioned before, prednisone doesn't do a lot to increase your risk. So here's a really fascinating paper that was recently published in the Journal of the American Academy of Dermatology. And look at the red arrows on the top. Those are scans that show skin cancer. And this person had an aggressive, undifferentiated epithelial tumor in the parotid. So it's not necessarily a skin cancer, but it did have skin metastasis. And the only thing they did was change the immunosuppressive from regimen A to regimen B. And when they did that and nothing else, the cancer went away. It just speaks to the importance of immunosuppression and its risk of causing skin cancer. Here's a medicine that I want you to pay attention. I'm going to go through this quickly, but if you see voriconazole on your medication list, you need to be seeing a dermatologist. This medicine alone, which is used to prevent invasive fungal infections in transplant patients, has about a threefold risk of getting squamous cell carcinoma. So this is a significant transplant risk medication. So if you have this medicine, make sure you're seeing a dermatologist. Here's another thing that we don't think about often, but something we noticed in our specialty clinic in Philadelphia when we looked at our demographics. You'll notice that this picture is of a darker skinned patient. And this is something that people aren't and haven't been great at recognizing, but we're getting much better at. Darker skinned patients can get skin cancer, especially transplant patients. What happens with the darker skin patients is that sometimes the lesions are ignored or dismissed or not treated with the same aggressive way that we would in a light skin patients, because lesions look different in darker skin patients. This patient had a biopsy proven skin cancer, but still hadn't seen a dermatologist for quite some time. And only after he came to see me was he able to get Mohs surgery. But at that point, the skin cancer had really progressed. And he ended up needing many, many additional therapies because this was an invasive skin cancer that wasn't really picked up at an early time. So somebody actually asked this question, which is why I included it. There are unique differences regarding skin cancers in patients of darker skin types. So we actually published some of our findings of non-melanoma skin cancer in non-white organ transplant patients. And one of the things we noticed is that you need to look in areas where the sun doesn't shine. So sometimes these skin cancers are growing in the genital area or non-sun exposed areas, and sometimes they are associated with viral lesions. So HPV and other viruses that can predispose you at baseline to getting a skin cancer. Now, if you add in the mix of being a transplant patient, it further increases that risk. So skin cancer in people of color, whether you have a transplant or not, is often diagnosed at a later stage. So this is something that we have to pay attention to. And you also notice that the survival for melanoma in African Americans is the lowest, and that needs to change. Mohs surgery is the way we treat a lot of skin cancer. I'll keep this brief, but I just want you to know this is a technique where we reserve it for skin cancers in high-risk locations like the face and high-risk tumors. So not every lesion needs to be treated with Mohs surgeon, but you really want to be seeing a board-certified and fellowship-trained Mohs surgeon who knows how to handle high-risk skin cancers. Even if you don't have one now, you want to have a relationship with a Mohs surgeon like this. Mohs surgery offers you the highest cure rate for skin cancer in certain locations. It's the most precise way of treating because it allows an examination of 100% of the margin, and you get the best outcome because you have the smallest hole with the maximal functional and aesthetic effects. So here are just a couple of examples. People are often scared about having Mohs surgery, and one of the things I often hear is, oh, it wasn't as bad as I thought it was going to be. You know, unfortunately, people with transplants become used to having skin cancer and they know this, but early on you become very scared of the unknown. And here are some examples, I'm just going to go through them quickly, of basal cell, squamous cell, and how we treat them. And you'll see in the end, you know, it's often not as bad as you think. Here's a melanoma that we treated. You can see the before and the after, and just not even a few months later. Same, ears is a location that we consider high risk. So if you have a skin cancer on the lip and the ear, you want to get into the dermatologist more quickly than say on your arm or your leg. Here's a forehead skin cancer. Mohs is the gold standard for suitable skin cancers. Again, not all of them need it, but you also have other ways. And with skin cancers in transplant patients, you often have to treat in a variety of ways. You know, you can't always do Mohs. You don't always want to freeze. Sometimes you don't always want to scrape and burn. It's a variety of perfect lesion with a perfect match to the best treatment for it. And you need to have a good relationship with a dermatologist who knows how to do a variety of things so that you can, you know, get through the time quickly and efficiently. So Mohs is the gold standard, but sometimes all you need is just a regular excision where you cut it out and stitch it up. We have a procedure called electrodesiccation and curettage where we can just scrape and burn a skin cancer, which is a good way of treating, but you don't always have to, you know, do a more aggressive way. You know, some of these have pros and cons. Like, for example, for this, you don't always have pathologic confirmation that the tumor is removed. We sometimes just freeze a skin cancer off. Radiation treatment, you'll hear about that. You know, I reserve radiation for non-surgical candidates or for patients who need what we call adjuvant therapy, meaning that the cancer has perhaps spread around the nerve. We might do Mohs and then give you radiation. Medical management is a way to treat some skin cancer. So we have topical chemotherapy that we can use. And sometimes we have systemic medications that we use for like larger tumors or unfortunately metastatic skin cancers. Somebody asked in the chat, is image-guided SRT or superficial radiation as a surgery-free treatment effective for basal and squamous cell carcinoma? This is becoming increasingly common and almost having a resurgence. In my opinion, Mohs surgery remains the gold standard and offers you the highest cure rate for these skin cancers. Superficial radiation is out there and more people are offering, but it's not new. It's a way where you would have radiation for 4 to 6 weeks. The problem with it is that there are side effects of having radiation for 4 to 6 weeks, including radiation that causes an increased risk of getting yet another skin cancer on top of that. There are also rashes that you could get. You know, you don't also get the confirmation that the skin cancer is gone. You know, it works okay, but it does have recurrence rates that are higher than surgical approaches. You know, it's a conversation you need to have with your transplant dermatologist and somebody who specializes in skin cancer to really be able to distinguish if it's a lesion that is amenable to that. Here, you know, again, as an important just reminder slide, you want to beware, but be aware. So you want to prevent skin cancer, catch them early, work as a multidisciplinary team, know what to do and how to intervene. So what should you do? Number 1 is be seen by a dermatologist. 2, wear sunscreen. And number 3, keep wearing your sunscreen, but start adding in other things like ultraviolet protective clothing. Here are a couple things. I talked about skin cancer on the lip. Sorry about the graphic photo, but this is an important area to recognize. That spot was much smaller. I wish I had the before picture before that spot on that you see on the lip. So you want to choose the shady side of the street. Always wear sunscreen, SPF 30. I tell my patients, don't waste your money on SPF higher than 45. It doesn't help you. Reapply after 2 hours, and you need more sunscreen than you think. Don't forget to lip balm. We talked about the clothing. Hats are really important. A wide brim hat. One of my patients told me that one of their transplant dermatologists told them, if your people aren't making fun of your hat, the brim isn't wide enough. And don't forget the eyes, sunglasses. We see a lot of skin cancers around the eyes, as you see there. And there's also eyeshadow that you can use that has sunblock built in. Somebody asked how often you should be seeing a dermatologist. It depends on your risk. Around the time of transplant, you should see somebody like you saw the person in Virginia. They wouldn't even transplant them until they had an evaluation. But then it depends, you know, sometimes every 6 months, if you're higher risk, we might see you every 3 months, but most of the time, every 6 to 12 months is adequate. This slide, I'm just going to go quickly through because we're running out of time. It just proves that sunscreen and talking about sunscreen works. Patients who were counseled on sunscreen and given sunscreen had lower rates of skin cancer than transplant patients who did not receive that counseling. What is the best sunscreen? Somebody had asked that. The best sunscreen, as you've heard other dermatologists say, is the one you're actually going to use. I tell people it should be just like brushing your teeth. You don't leave the house without doing that. You shouldn't leave the house without putting on sunscreen. SPF 30 or higher. Mineral sunscreens are really good, zinc and titanium, and now they make really cosmetic formulations that are elegant and rub on quickly. When you're at your dermatologist, ask for sunscreen samples. Try the ones out that you have and see the ones that you like. Most importantly, I found out that sunscreens expire. And we actually did a story on this. We went to the beach and looked and asked people to show us what's in their sunscreen bag. And a lot of them had expired sunscreen. Sunscreen we think lasts about 3 years. So make sure that if it doesn't have an expiration date, you're checking the bottle. If it does, and if it doesn't, it lasts only about 3 years. Specialty dermatology clinics do make a difference. So if you've been referred to a transplant dermatology clinic, that is really good. They're more likely to use sunscreen and they have better sunscreen awareness. This is a paper that just came out. And you can see the conclusion is that it's imperative that solid organ transplant recipients, you, have early access to skin protection education and regular skin cancer monitoring. So other things that you can do, not without talking to your doctor, as Talia pointed out, is vitamin B. That's something we learned from our Australian colleagues. It reduces the risk of non-melanoma skin cancer in high-risk skin cancer patients, which transplant patients are, by about 23%. Sometimes if you're developing many skin cancers or too many or an aggressive one, we sometimes will start you on retinoids. You've heard of things like isotretinoin, which is the brand name of Accutane. You can take that or etretinoin, which is another one that we use. These are the reasons why you might want to start on this. This isn't something you need to know, but something you should be talking to your transplant dermatologist about. If you have multiple skin cancers a year in the range of 5 to 10 per year, multiple and high risk locations, or you start to get them in an explosive or eruptive pattern, then you want to be sure to talk to your dermatologist about these adjuvant treatments. So I'm going to end there. Transplant dermatology is a small but growing field. Post-transplant immunosuppression is a game changer for the risk of developing skin cancers. And we all want to work together. So like we said at the beginning, no one dies from getting skin cancer after a life-saving transplant. I see one quick question about, is it okay not to wear sunscreen outside for short periods? No, we don't think you should wear sunscreen you should go outside without sunscreen. I know people say about, oh, vitamin D, you can supplement with vitamin D, but if you're a transplant patient, you think you're getting a lot of sunscreen when you put it on, you're always skipping areas and you're still going to make some vitamin D, and you should always wear sunscreen. All right.
Thank you so much, Dr. Mark. That was just incredible. And you did a really wonderful job of answering, as we went, a lot of the questions in the chat. So I'm just going to quickly go back through the Q&A and see if we have any unanswered questions in there.
Yeah, I try to keep an eye. I may have missed some, but somebody can ask one now, or I can go through it.
Yeah, if anyone has any last minute questions, or if your question got lost in the chat, feel free to ask it again in the Q&A. There was one question about clothing. You mentioned at the end there UV clothing. Is that this question?
Yes.
Is that a specific brand or?
I don't have a specific brand, but there are many brands, some of them even designed by dermatologists. But many of the major brands have them. They do have a factor, just like SPF does, 15, 30. So you'll see that. So SPF 30 or UPF 40, and that's in the clothing. You need to still wear sunscreen in the parts that aren't covered by the clothing, obviously. And then the other thing about the clothing is you need to keep in mind the number of washes. So sometimes they're good for 40 washes or 50 washes. There are also things you can put in your detergents in your washing machine to add sun protective factors into the clothing. I think there's less strong science behind that. So we really want to focus on sunblock and UPF clothing and hats and sunglasses.
Thank you. Another question, someone mentioned they don't have access to a transplant savvy dermatology program. So their question was, are cosmetic laser procedures like hair removal, acne treatment, etc., safe for transplant patients in terms of skin cancer risks? Okay,
so the risk is because of ionizing radiation. So what's not safe is light from the sun, light from a tanning bed. Radiation, some of that is ionizing. But laser hair removal is non-ionizing radiation. That is safe and does not increase your risk of skin cancer. And what was the other thing they said? Laser hair removal and what else?
Different acne treatments.
Oh, different acne treatments. Some people do use some light treatments for acne, so certain wavelengths of light. As long as they're not ultraviolet light, it's safe. So there are wavelengths that are safe, and most of the ones that are for acne are safe. They're in the 400 range, which is outside of the ultraviolet light range.
Okay, and one of the, there were actually multiple questions that people mentioned that they had a precancerous spot identified and had been given samples of different ointments that were helping. However, they weren't covered by their insurance. So, and it asked if you had any suggestions on.
Yes, we do run into this sometimes. So there are a couple of creams that we use as what we call chemo prevention or prophylaxis. So you can use them to treat precancers or even some cancers. There are common ones and uncommon ones. You know, one good thing about going through years and years of this is that there are some that are generic. So ask your doctor for a generic one. There are some designer ones, and those often are not covered by insurance companies just yet. But there are plenty of options that are covered. So it's about asking the right questions, asking for a generic one, or sometimes working through parallel panels. For example, a specialty pharmacy that can compound it. Instead of paying several $100s, it might just be $20 or $30. So look for a generic drug or a compounding or specialty pharmacy that may have worked with a transplant team before.
Okay, and then some final questions here. As far as applying sunscreen in your skincare routine, is there an order that it should be applied? So should SPF be put on as your last step or first? Does it matter?
It should be your last step ideally, but that's not possible if you wear makeup. So then it'll be right before your makeup. But it should be the last thing. The only caveat is bug spray. So you would put your bug spray after your sunblock. But if you're not using bug spray, then sunblock should be your last.
Great. So let me look back through the chat. I think we got all of them in the Q&A. And then it looks like there are, I think we got to most of the questions in the chat. If your question was not addressed, it may have gotten lost at some point, please send us an email and we can send it on to Dr. Mark. And if he's willing to give us an answer, we'll reach back out.
Absolutely, absolutely.
Wonderful. Again, thank you so much, Dr. Mark. This was so wonderful and so informative. And the chat recognized that throughout your presentation. If anyone has any follow-up questions, please feel free to reach out. And again, you will be receiving an email tomorrow with the survey, as well as all of the resources from today's presentation. So thank you again, all of you, for being here and for your participation. And Dr. Mark, thank you again for your time and your expertise.
Of course. Sorry about the glitch in the beginning.
No problem. Thank you all so much. Have a great afternoon.